Hey, welcome to this video. We will talk about metabolic syndrome. So, what is it? The World Health Organization defined it as the presence of insulin resistance in addition to two of the following risk factors: obesity, hyperlipidemia, which includes hypertriglyceridemia and low levels of high-density lipoprotein cholesterol, hypertension, or microalbuminuria. In other words, it's a cluster of metabolic abnormalities that includes hypertension, central obesity, insulin resistance, and atherogenic dyslipidemia. And what are the causes? Many contributing factors and mechanisms have been proposed, including insulin resistance, adipose tissue dysfunction, chronic inflammation, oxidative stress, circadian disruption, cellular dysfunction by protein kinesis and phosphatases, suppression of insulin receptor substrate 1 and 2 gene expression and function, obesity, lipid and glucose toxicity. Next, the physiopathology includes genetic and acquired factors. Obesity is related to a variety of chronic disease, where the non-esterified fatty acids levels are high. These have been shown to be an important contributor to insulin resistance by blocking insulin receptor substrate 1. Consequently, it inhibits the glucose uptake.
Insulin resistance, insulin increases glucose uptake in muscle and liver and inhibits lipolysis and hepatic gluconeogenesis, leading to an increase in circulating free fat acids that further inhibit the lipolytic effect of insulin, which causes a hyperinsulinemic state where eventually the compensation fails and insulin secretion decreases. Now, adipose tissue with adipokines as tumor necrosis factor alpha cause phosphorylation and inactivation of insulin receptors in the adipose tissue as well as in smooth muscle cells. This induction of lipolysis increases free fat acid load. Leptin is secreted by adipocytes to signal the brain for satiety. Normally, as fat cells expand, more leptin is secreted, but obese people develop leptin resistance. Growth of adipose tissue during obesity development more angiotensinogen secretion, and it leads to an increase of blood pressure and the creation of reactive oxygen species. Adiponectin is an anti-inflammatory and anti-atherogenic adipokine, and it affects underdose of leptin. An increase in adipose tissue mass correlates with reduced adiponectin and higher leptin levels. Now, the atherosclerosis is caused by oxidation of small and dense LDL product of the lipotoxicity.
Most of the disorders associated with metabolic syndrome don't have obvious signs or symptoms. One sign that is visible is the increased waist circumference. Other ones like high blood pressure, dyslipidemia, central obesity, and glucose intolerance are the typical clinical manifestations.
There are many clinical criteria made for the diagnosis of metabolic syndrome around the world. We are focusing on the three following: the National Cholesterol Education Program ALT Treatment Panel 3, the International Diabetes Federation 2005, and the Joint IDF NHLBI 2009 criteria. For all of the three criteria, the metabolic syndrome diagnosis must follow 3 out of 5 of the next evaluation contents. The obesity level based on waist circumference must be population specific, except on the first criteria, which marks equal or greater than 102 cm for men and 88 cm for women. Glucose levels must be equal or greater than 100 mg per deciliter. Triglycerides levels have to be equal or greater than 150 mg per deciliter. HDL cholesterol levels must be equal or less than 40 mg per deciliter in men and 50 mg per deciliter in women, with their specifications. And blood pressure level has to be equal or greater than 130 over 85 mercury millimeters on antihypertensive therapy.
The basis of the treatment is a low-calorie diet that helps us reduce weight. A few days after starting a low-calorie diet, insulin resistance is reduced, and even before weight loss occurs. Here are some recommendations. Avoid simple carbohydrates. Prefer complex carbohydrates. Add soluble fiber to the diet. Avoid saturated fats. Prefer cooked or roast food rather than fried. Pharmacotherapy. The pharmacological treatment of insulin resistance is mainly based on three groups of drugs. Alpha-glucosidase inhibitors that effectively increase insulin resistance. Biochemistry, represented by metformin, that increase insulin-induced peripheral glucose uptake and liver production thereof, and the azoxystrobinodiones that increase insulin sensitivity. Lipid-lowering therapy has been shown to reduce the rate of cardiovascular events and mortality. It has been suggested that lowering triglyceride levels, especially postprandial, may improve glucose metabolism and decrease atherogenic risk. The use of fibrates has been shown to decrease triglyceride and fibrinogen levels, while increasing HDL-C. On the other hand, the decrease in insulin resistance increases HDL-C levels and with this decreases heterogenic risk.
We can conclude that metabolic syndrome is a disease that clearly affects the population of our country and around the world. However, it is a disease that can be prevented, so it is important to take care of our health, maintain good habits, and have a culture of disease prevention.